Welcome everyone. We at ASG Academic Cell have been doing a few webinars on various topics of importance with speakers from uh, outside the country and also from inside the country. Dr. Singul was with us discussing pediatric retinal detachment, and we had a class with Professor MGFC on inverted ILM flap technique. Next. And we called Dr. Barbara Parolini to discuss vitreoretinal interface disorders, and Dr. Zofia Anna Noroka was there to discuss optic disc pit maculopathy. And we had classes with Dr. Ahmed Salam on scleral buckling, and Dr. Neto Rezatili took a class on taming heart cataract. We had Dr. Rajeev twice with us, first on the art of pneumatic retinopexy, and next on imaging and integrity in retinal detachment repair. So Ulrich Spandau was with us to discuss the management of proliferative vitreoretinopathy. And Pramod Bhende was there to discuss diabetic vitrectomy, and we had Professor J.S. TTL to discuss the outcomes of toric IOL. And Mahesh Shanmugam sir was there to discuss retinal detachment, and we had Dr. Avinash Pathenge to discuss acute retinal necrosis. So all of these videos are available in the YouTube channel. Dr. Parveen Sen ma'am discussed idiopathic polypoidal choroidal vasculopathy, and our own Dr. Atul Dhawan had a class on macular hole. And Dr. TTL sir again took classes on decision making in refractive surgery and also dilemmas in refractive surgery. So we had another class on myopia and rheumatoid retinal detachment with Dr. Dinesh Talwar sir, and Dr. Muna Bhende ma'am we had a webinar on optical coherence tomography biomarkers. So we had two classes with Dr. Omon Maharu sir on inherited retinal disease, and we had a class on 10-step approach to myopia progression by Dr. Manjula ma'am. So we had a class with Dr. Saurabh Patwardhan sir on phacoemulsification also, and this is the second class with Dr. Omar Maharu, in which he discussed he showed various cases of inherited retinal diseases and how we can diagnose from their phenotypic features. So we welcome you all to this webinar with Dr. Rajeev Muni, where he and our panelists will discuss a few cases of pneumatic retinopexy. Dr. Jain, please introduce our speakers and panelists, and we'll then go to Dr. Kunihiko.
Yeah, thank you, Dr. Kaushik. So, Dr. Rajeev Muni, all of us know he is someone who has brought a new life to the technique of pneumatic retinopexy across the globe. He's a staff vitreoretinal surgeon at St. Michael's Hospital, the Hospital for Sick Children, and the Kennington Eye Institute in Toronto, Canada. He's associate professor and vice chair of clinical research in the Department of Ophthalmology and Vision Sciences, University of Toronto. Dr. Muni and his team conducted the pivot randomized trial comparing pneumatic retinopexy versus pars plana vitrectomy for rhegmatogenous retinal detachment repair. Dr. Muni has over 200 peer-reviewed publications. He has also been instrumental in novel research assessing the integrity of retinal reattachment with various surgical approaches using multimodal imaging, and has published extensively on this topic in the highest impact journals in our field. Dr. Muni has won several awards, like in 2018, he received Eye Physicians and Surgeons of Ontario Innovator of the Year Award. In 2021, he won the inaugural Kreisig Award for Excellence in Retinal Surgery from the Association of Vision and Research in Ophthalmology. In 2022, he won the inaugural Rosario Brantaco Retina Award from Italy. In 2023, he won the Retina Research Foundation Kaiser Global Award from the Pan American Association of Ophthalmology, the highest honor given by this association for research. In 2023, he also was one of the 5 recipients of the inaugural Presidential Honor Award from the ASRS. Next, I would like to welcome our esteemed panelist, Dr. Francesco Pellegrini. Sir is the chief in the Department of Ophthalmology at ASFO Pordenone, Italy. He has over 120 PubMed Index publications. Sir has been a speaker at national and international level at various conferences. He is a reviewer for Journal of Clinical Medicine, European Journal of Ophthalmology, and Survey of Ophthalmology. He has a special interest in vitreoretina, neuro-ophthalmology, retinal and glaucoma imaging, retinal regeneration. We have with us today Dr. Kunihiko Akiyama. He is the Chief in Department of Ophthalmology at National Hospital Organization, Tokyo Medical Center. He graduated in 1995 from the School of Medicine, Keio University, Tokyo, Japan. Since 2003, he is the clinical investigator in Institute of Sensory Organs, National Hospital Organization, Tokyo Medical Center. He has 25 publications which have been cited more than 400 times. We also have one of the panelists from India, Dr. Vishal Govindahari. He is the Vice Chairman and Vitreoretina Consultant at Pushpagiri Vitreoretina Institute, Hyderabad and Vizianagaram. He did his Vitreoretina Fellowship from LVPI Hyderabad. His main area of interest includes innovation in community eye care, aspiring to serve all segments of society by creating sustainable, affordable, and quality eye care facilities in India. He has presented various research papers at regional, national, and international conferences. He has more than 20 research article publications in high-quality national and international journals. He has received the research fellowship under the Bayer Global Ophthalmology Program in 2020. He has been co-principal investigator and consultant ophthalmologist in 2 public health projects with the United States Agency for International Development's Childhood Blindness Prevention Program. He also received Video Presentation Award at the annual Asia Pacific Vitreoretina Society Congress in 2007 at Kuala Lumpur, Malaysia. So I welcome Dr. Rajeev Muni sir and all our esteemed panelists. So I think, Dr. Kaushik, we can start with some of the presentations from our panelists before Dr. Rajeev sir can take over.
Yes, Dr. Kunihiko, please.
Okay, before showing my case, let me start from my story, how I could learn pneumatic retinopexy in Japan. In Japan, when I studied retinopexy, there was nobody doing this around me. So I didn't have in-person training. So when I got interested in pneumatic retinopexy through reading the paper Pivot study, I started asking questions by email to Dr. Muni. Then I joined the social media group. There is a very large number of people joining this group. And there I learned and I joined the discussion about cases for about 6 months or longer. Then I got many knowledge about pneumatic as well as my own experience as a surgeon to treat retinal detachment. So during these 6 months, I was looking for my best case for pneumatic, my first case for pneumatic, which was in the COVID-19 pandemic. And maybe, I really wanted to start with a very simple case with a single retinal break in the superior quadrant. But unfortunately, my first case was not such cases. So, oh, I can't find my slide. I can't share my slide. What's happening? Oh, here it is. So I can't believe this. Still, I can't believe, but this is my first case. A 60-year-old male, visual acuity hand motion. There was many retinal breaks in the here, and another one here. And here is latch generation and 2 more breaks in the attached retina. So there was 2 or 3 retinal breaks in the detached retina and 2 more in the attached retina. This was my first case. But so maybe some of you may think such a case cannot be treated by pneumatic pexy, but I tried it because this patient strongly wanted to avoid going to the operation room in the COVID-19 pandemic. So I decided to do pneumatic this patient. So we must consider how to treat these 3 breaks, which are separate to each other. So first, I I injected gas, 0.6 milliliter SF6, and I concentrated on these two breaks. So I asked the patient to keep head position to support these two breaks. Then on the next day, these breaks were sealed. So I started laser around here. But of course, this break was not sealed, and in this area, the retinal detachment still remained. So then after 1 week or so, so this is day 3 after the first injection. So these retinal breaks were sealed. I could do laser. However, this break was still open. So I injected the second injection, and on the about 2 or 3 days later, and then I changed the head position to support this side. Then the fluid in this area disappeared, and I could do laser. So doing injection twice and changing the head position, I could treat all of these breaks, these separate breaks, and finally the retina is fully reattached, and the visual acuity was recovered to 0.7 from hand motion. So even if your first case is such a complicated cases, you can try to treat such cases if you have good knowledge about pneumatic. And to me, the best way to get good knowledge about pneumatic was the social media. There I could learn many things. Still I'm learning many things. And sometimes I could suggest some suggestion to younger surgeons. So I really recommend to learn in the social media if you don't have an in-person training. Thank you very much.
Thank you, Dr. Kunihiko. We'll now request Dr. Rajeev Muni to please share his cases on pneumatic retinopexy from simple to the most difficult ones.
Sure. Well, welcome everyone. I'm just going to load my slides here. And Vishal, Francesco, and Kunihiko, please feel free to interrupt at any time if you want to add a pearl or discuss anything. And you know, I've given several talks in India about pneumatic retinopexy. So this time, you know, I think what we should do is, you know, if there's any questions, just, you know, post in the chat perhaps that you have a question, or post it there, and we can interrupt in the presentation. We can just address them right then and there, because sometimes at the end, you know, at the end nobody kind of remembers their questions. So let's start. If everyone can just mute, that'd be great. So today I'm going to talk about pneumatic retinopexy cases for simple to complex. And you guys can all see my slides, I assume?
Yes.
Yes? Yeah, okay, thank you. So the first question is a very basic question. Why should we learn pneumatic retinopexy? You know, we have so many ways of fixing detachments, buccal, vitrectomy, and these are good techniques that have high single operation success rates. So why should we learn a technique that may have a lower single operation success? And the key is that over the last 5 to 10 years, it's become very clear that the outcomes with pneumatic retinopexy, the outcomes for the patient in terms of vision, distortion, invasiveness, maintaining phakic status, quality of life, all of these things are better with pneumatics when they work. So when a pneumatic works, you have a better outcome and a better integrity of attachment. The retina is reattached in a less distorted and stretched manner. And therefore, currently, it's one of the best approaches that's minimally invasive, that allows you to restore the integrity of the retina, which you do not get with a pars plana vitrectomy. Now, with a scleral buckle, you can get that as well with non-drainage. However, you know, we know that this is a more invasive procedure. So my two favorite procedures are pneumatics and segmental buckles, for example. You know, just today we did a segmental buckle as our first case. We did a failed pneumatic as our second case in the OR before I came here. So this is how we manage, and we do this because we have data to support what we're saying. The PIVOT trial was a randomized controlled trial that showed that visual acuity outcomes were superior in the PIVOT trial at every time point, including the 1-year endpoint, by 10 letters at 3 months and 6 months, and by 5 letters at 1 year. And also patients had less vertical metamorphopsia. And this is an example of a patient who would meet pivot trial criteria more or less, where you have breaks within 1 clock hour. And we included patients who had breaks within 1 clock hour, single or multiple, but all the breaks in detached retina had to be above the 8 and 4 o'clock meridians. And you could have extensive lattice, or you could have any pathology in attached retina. That was fine, as long as the breaks in detached retina were above 8 and 4 o'clock and within 1 clock hour. Now, this was the primary outcome from the pivot trial, and here you can see in blue, the pneumatic group, always better than the vitrectomy group at every time point. And vertical metamorphopsia was worse in the vitrectomy group, both in terms of the severity as well as in terms of the frequency. When you look at success rate, of course, it's going to be lower with pneumatic versus a vitrectomy, but the difference was 11%, or about 12% difference in success rate. So let's keep that in mind, because we're going to come back to that point later. So what is the patient like? Well, when we did the National Eye Institute Visual Function Questionnaire in this randomized controlled trial, VFQ was superior for pneumatic at 3 months and 6 months. And that includes with the increased visits, it includes with the patient positioning requirements and everything. By 1 year, the two groups were more or less the same. Also, we know that in the vitrectomy group, everyone's going to require a cataract surgery within the first year. So in summary, pneumatic had superior visual acuity, lower success rate in the pneumatic group by 12%. But the key was that when a pneumatic failed, it did not jeopardize the final outcome. And it's a durable treatment. After 3 months, no one redetaches essentially, even over long durations. And there's less morbidity, less need for cataract surgery. So before we get into the cases, I'm just going to go over some of the myths that you're going to hear people say about pneumatic retinopexy. Number one, they'll say it doesn't work because you're not relieving traction. So this is what we're taught in all our fellowships. We have to relieve traction. When we have a horseshoe tear, we don't relieve traction. We do laser around the break and it attaches. It almost never will break through that laser because the adhesion overcomes the traction. So in a pneumatic, all you're doing is you're reversing the process to when you originally had a break. And you have a break with traction now. You've reversed the retinal detachment by the gas bubble and by expressing fluid out from the break. So if you need to relieve traction by doing a vitrectomy, then if that's your argument, you would have to do a vitrectomy in every horseshoe tear, which is ridiculous. And so for the same reason, it doesn't make sense to do a vitrectomy to relieve traction. In fact, when we look at, some people will say the gas bubble from a pneumatic causes traction on the inferior retina and causes new breaks. But when we look at, with ultra wide fields OCT, and you look at the traction on the inferior retina, for example, when you have lattice degeneration, there's going to be adhesions and traction. And we put the bubble in, and before and after the bubble, we see no change in the conformation or configuration of the retina. We don't see any obvious tenting of the retina more because of the bubble. This is a myth. You know, you'll see the picture of the bubble being pushed up and the vitreous being dragged up with the bubble. This was in someone's mind, not in real science. So the other myth is that pneumatic is not a long-term solution, as the retina will eventually redetach. I showed you how the success rate is after 3 months is very high. There's very few patients will redetach. And we just published our long-term outcomes from the pivot trial up to 5 years, with essentially no recurrent detachments in either group, except one. And others will say, well, when a pneumatic fails, you get a high risk of PVR. Now, with 2 randomized trials, almost 400 to 500 patients altogether, we haven't seen a high risk of PVR. And the reason is because when a pneumatic fails, you have to go to the OR soon. Another myth is they'll say, well, I don't want to keep following these patients every day, 5 times in the first week, and they have to keep coming back. If you look at the number of visits that you have to take in the pivot trial, in the pneumatic group altogether, it was 10.8 visits versus 9.6 in the vitrectomy group over 1 year. And this doesn't even include the extra visits for the cataract and associated issues. So that's my spiel for to convince you why this is important for you to learn. And now we're going to get into the actual technique and the procedure. So here is the video that kind of shows my approach. Just stalled a little bit. 1 second. I just stopped sharing for a second. I think it just froze. We will. Let me come out of the presentation, see if I can get it to play.
Yes, I think you can open the video itself.
Yeah. Just 1 minute here, sorry. Okay, I think we're out. Let me just see. No, this video is not playing. 1 second. Okay, I'm just gonna move forward. Yeah, we'll see if we can get the video up after. Okay, so okay, so we'll show the video after, but basically when we look at we do the technique, we want to do a large anterior chamber paracentesis, and then we want to inject the gas. We go halfway in with a 30 gauge needle and then pull back so the tip is barely in the eye. And then we will expand the bubble. And Kunihiko, you may have this video of the procedure. I don't know if you have one or not from one of the previous talks. If you find it, let me know, and then we can let you share the screen. I much prefer using SF6 gas because it expands very quickly, it rapidly expands, and it goes away very quickly. So it goes away within 12 days. C3F8, often people will inject smaller bubbles because they're afraid to put in too much gas. And when you put a smaller bubble, it takes 4 days to reach its maximum size, which is very slow. And then it lasts 38 days inside the eye. And I believe that when you put a 0.3 cc C3F8 bubble, there's a higher risk of subretinal gas, particularly when you don't steamroll. So we like to use SF6 gas with a very large gas bubble, okay? And we like to steamroll always. And this gives you a big bubble quickly. You express the fluid from the break even before the bubble reaches the break, and then the gas will go away. Now, all pathology in attached retina, we're going to laser first before the gas bubble injection, and then immediately after we will inject the gas. And we will laser all pathology, even lattice degeneration, sometimes even vitreoretinal tags, atrophic holes, horseshoe tears in attached retina. All of it will be treated. Now, when we inject the gas, here you can see we are going halfway in, and then we pull back so the tip is barely in the eye, and then we inject the gas. And again, the videos don't seem to be working here, but essentially you go halfway in and then you pull back so only the tip is in the eye, and then the gas will be injected, not too fast and not too slow. And also you want to hold the plunger down while you're coming out, because otherwise the gas will reflux into the syringe. This is how we do the steamrolling. So we will do face down for 6 hours and then gradually raise our head, 30 degrees every hour until the patient reaches the head elevated position. And I'm going to say that it's very important to use topical steroid eye drops because When you do laser afterwards, if you haven't put the patient on steroids, their eye will be quite sore or tender. And so by using steroid eye drops, prednisone 4 or 5 times a day, it'll keep the eye quiet and make the laser easier. So now let's go through some cases, and we're going to go through a whole bunch of cases. And, here I'd like to ask the panel, Kunihiko and Francesco and Vishal and anyone else who has comments, just stop and let's discuss around these cases, okay? So let's just start with a really basic, simple case. This is a patient who has latus superiorly and latus inferiorly, a horseshoe tear, or kind of like a radial sort of tear superiorly. So this is a great case for pneumatic within 1 clock hour. It meets pivot trial criteria. And here you can see at 2 hours, we got a lot of fish eggs. Now, maybe at this point, I'm going to stop. Kunihiko, why did we get fish eggs? What are the reasons why we might have gotten fish eggs in this case?
The fish eggs occurs when the needle go too deeply into the eye, and when we inject too slowly, and when we inject from a location which is not at the top of the eyeball. If we inject from inferior part, then there would be fish eggs. So these 3 factors are related to fish eggs, I think.
Yeah, exactly. Yes, go ahead, Francesco.
Yes, thank you very much for inviting me. Hello, Rajeev. And I think another good reason for having a lot of fish eggs is that you don't do an adequate AC tap. I mean, if you want to have a single large bubble, you have to lower the intraocular pressure so you can get the space to inject the bubble into one bubble. When you have an high pressure of the eye because of inadequate AC tap, you just have one bubble and then another bubble and then another bubble when you inject the gas bubble. So another risk factor is a not proper AC tap before injecting the gas.
Yeah, it makes sense that if you had a lot of high pressure, then there may be more turbulence when you're injecting versus a soft eye. I've never thought about that, and I don't know. I don't know for sure how much that contributes, but it makes sense what you're saying. And Kunihiko, I agree with your points that you want to go halfway and pull back so the tip not too deep, and you never want to inject from inferior where the one bubble is going to come off at a time. So Vishal, what do you do if you get a lot of fish eggs? So let's say you had a very large break, gaping break, you are worried about the fish eggs. Like what's your strategy in that situation?
Thank you for the opportunity. I normally try and do the prone slightly longer and let the bubbles fuse. It sort of keeps the bubbles away from the break and then go to break, because normally we find that fish eggs, as you can see, within 24 hours is in the picture here, is almost gone. Just a small mini egg is left, and then there's one large bubble. So we normally try to give prone and then see that the bubble, all of them fuse together and then go to break.
Yeah, exactly. I think that there's no harm in delaying the full reattachment for 24 hours. So worst case scenario, especially if you're worried about subretinal gas, you can do a very slow steam roll, which we normally do anyway, 6 hours face down and then gradually raise your head. But there's no harm even in 24 hours face down, because as the SF6 rapidly expands, it's going to come together and you're going to be able to get rid of most of the fish eggs. And also, by the time the bubble reaches the break with the steam rolling, the retina is already attached, because even though you haven't tamponaded the break, you've expressed the fluid through the break. And so when the gas reaches there, even though you still may have fish eggs, the break is now settled and the gas will not go through the break. So the key is a large bubble, do some additional face down if you end up getting lots of fish eggs, then do a slow steam roll, and you'll be fine. Now, in this case, we weren't really worried about it. The reality is, even with fish eggs, the majority of the time, the standard 6 hours and gradually raising your head will not allow for subretinal gas to go in. I would say the risk of subretinal gas is quite rare in our practice, maybe 1 out of a couple hundred cases, maybe, where we get it. So, and we'll talk more about that. So let's go to another case. This is a 68-year-old male phakic and 2300 vision. And here you see probably there's some choroidal. There's a superior retinal break as well. And the inferior retina is bullously detached. You might even have some early intraretinal PVR down there. So kind of a chronic looking detachment. But the basic principle of pneumatic retinopexy is treat the break. So here your break is superior. The inferior PVR and chronicity doesn't really bother us if there's no break down below and there's no traction on the break. So here you can do a pneumatic, and we never put in less than 0.6 cc's of gas, and we do our procedure. And now look, the retina is starting to attach. You see the nasal choroidal. You see the break up top is more or less attached. And look, you do see some intraretinal PVR types of changes, starfold inferiorly, okay? Very similar to how we would do a buckle, right? When we do a buckle, we don't always remove the PVR. Now we've treated the retinal break, and the retina will settle. And why does the PVR not cause an issue? Because we've converted the detachment from a dysregulated situation where you're getting PVR to a regulated situation. The PVR process will stop, and whatever is there will be there. And because there's no break down there, it causes absolutely no issue. So you don't need to chase that PVR. So I would like to ask the panel for feedback on what's your approach to PVR in pneumatics. Like, what do you never consider a pneumatic when you see any PVR? Is it case dependent? How do you guys make your decision? So maybe Francesco, why don't you start?
Yes, well, one consideration about this case is that when you have a bullous inferior retinal detachment, usually the break is superior and not inferior. That's really important because you have Optos machine, so also people who are not doing a retina every day, they are really helped by Optos images, while I am a chief of ophthalmology department here, and not all of my colleagues, they do retina. So when they have to examine retina, I would like to have an Optos machine just to be, to do an easier retinal examination. This is the first consideration. And I did a few cases of retinal detachment by means of pneumatic with PVR. And I think that when you have, I'm really agree with you. The same reason is when you have subretinal strands of PVR and you do a buckle, you don't have to remove it. Is not mandatory to remove it to get the retina reattached. And the same principle is about pneumatic retinopexy. When you have a PVR subretinal or also retinal PVR with grade C PVR, that is a retina starfold, if it doesn't cause a real and visible traction nearby the tear, you can use pneumatic retinopexy. So indications and the contraindication are really not, standard. We should have a personal approach to every single case of retinal detachment. I think that with pneumatic, we could treat many more cases of retinal detachment that is generally done worldwide. And this is my, thinking about this, because we are doing many more cases than before with pneumatic, and also inferior, retinal breaks treated by means of pneumatics. Maybe we can have sometimes later. I prepared one such a case. So PVR is not a total contraindication for pneumatic retinopexy as long as it doesn't cause a real traction nearby the tear, I think.
Yeah, I agree with you. And, the one thing I would add is that when you have a PVR detachment, you've done a pneumatic, if it's not going well, probably abort sooner than later, so don't push it to the point where you're waiting a week or 2 weeks with a C3F8 bubble. And, because the key is that you want to get this fixed quickly. If the pneumatic's not working after 2-3 days, I'm probably going to the OR, and I haven't lost anything. But I'm not going to keep persevering if I think it's related to the PVR or there's something's not going well. just abort and go to surgery, and then you don't lose anything, you know?
Yes. Also, another consideration, as another case we did together for another webinar, the same approach is for retinal detachment associated with the vitreous hemorrhage. If you don't get the success soon, you have to go straight to vitrectomy, for example, or another procedure.
Great, and that's a great point. And this is really the art of pneumatics, is knowing when to give up and knowing when to persevere and continue. And this only comes with experience, and will change over time because you'll make some mistakes, you know. So this is a really important point, Francesco, as well. Situations like that, vitreous hemorrhage, you know, just complex cases in general, PVR, chronic cases, you know, your index of going to the OR is a little bit more, but you're still willing to try it in the first place. So let's switch gears now to another type of detachment. And these are called regulated detachments. Atrophic holes, hyaloids attached, chronic often, sometimes acute on chronic. And, you know, maybe I'll just ask Vishal, how do you change your approach to pneumatic retinopexy when you have a PVD or no PVD? What do you do differently, or anything? What's your general strategy?
So basically, if the patient does not have a PVD, I mean, the inclusion to pneumatic will not change whether there's a PVD or no PVD. That is, I think that has been proven eloquently enough. But the only thing is, if the PVD is happening as we do the pneumatic, then I think the follow-up schedule and the hedging with laser will be a little bit more. Where let us say especially if it's a pseudophakic as well, then you have a superior break and then you lasered it, but then I'd hedge it a little bit more, as you know, we've discussed with the multiple cases in Toronto, that you add more laser, a couple of clock hours on either side, bridging it all the way to ORA by indenting and then doing an LIO, to ensure that these micro breaks which get created and which follow link-offs will also get covered by your laser. So I would do a little bit more laser and more frequent follow-up.
Yeah, I think often in these cases, you know, it's not like a pseudophakic RD where you're missing breaks. So often in these cases, you can see all the breaks, you know where they are. So you do treat extensively all the lattice and holes. But I think the point that you made about follow-up is really critical, because we find that when you do not have a PVD, often they will get a PVD within a month of the pneumatic. And so in that time, when the hyaloid detaches, and whether you're detaching the hyaloid at a vitrectomy, or if it's later, you did a buccal and, you know, a year later they got a PVD, or you do a PVD induced by the bubble, you know, kind of stirs it up, or the detachment involving itself, you know, whenever you get a PVD, there's a risk of additional breaks, and you want to be there to catch those breaks when they happen, and you don't want them to redetach. Yes, Vishal.
It was one of the conferences, I mean, webinars which you had invited me, and I was obliged, I mean, very happy to be part of. Was I had a patient who had a pneumatic pseudophakic and single break, and treated and got back to 6/6 with good recovery. But 3 months later, the PVD happened, and despite the follow-up, the break opened up. And the lesson there was possibly inadequate, you know, sort of laser. Maybe we will deal with that in the next few cases, or, you know, we can touch upon it now. Is that so that happened, and then the patient had a recurrence post-pneumatic, and then we had to do a vitrectomy. Patient also unfortunately developed a choroidal, and it took a while for us to settle things back. The other thing which I'd like to bring to the foray here is the gas versus oil conundrum, which we use a lot more oil in India because of, it's still anecdotal. We don't understand why, because we need a stronger trial to prove it, that the way gas reacts in the eye is very different in at least our practices. And this is just a consensus which I'm trying to put through here. So a couple of things which I'd like to share, that the PVD can sometimes be, you know, wreak havoc if your laser is inadequate. So that's what I learned, and I really felt that, you know, I need to keep adding a lot of laser around, even if it's a single break.
Yeah, I think especially in a pseudophakic case, like what you showed, you know, where if you have a couple breaks at 10, 11 o'clock, you know, you should assume that you're missing a few breaks on either side. And so typically we'll do like a sectoral laser in the region, the high-risk region, kind of very similar to when we do a pseudophakic buckle and you'll put a tire or you'll put a band in at the extent of the RD. In a very similar way, we're not doing a buckle from the outside, but we're creating a barricade inside anteriorly in the region of the detachment. And the silicone oil versus gas is very interesting. I mean, in North America, we use very, very little silicone oil. I mean, it may also have to do just with the nature of follow-ups and the chronicity of detachments that you guys start with, and the appetite for recurrences and things like that. But generally speaking, we do gas, and when pneumatics fail, we'll often use gas. So let's move forward on this case. So here you have a gas bubble. We put it in. You can even see from the shape of the gas bubble that likely the hyaloid is still there and it's kind of compressing the bubble in different ways. And here you can see at a week, we have very nice laser around the break. Now, what are your thoughts, Kunihiko, about the action of the bubble on the break in the setting of an attached hyaloid? So the hyaloid's on, and you've put a bubble in, very similar to when you do a buckle and the hyaloid's attached. How does that change your thinking around doing pneumatics and kind of like what the bubble's actually doing? Do you know what I'm getting at?
I don't change my attitude, my strategy in such cases. I just do the same as the other cases with PVD. But such attached hyaloid cases, as you discussed earlier, there will be PVD may occur very soon after the gas injection. So I just observe very carefully. And in case when the there's any retinal tuft or degeneration which is suspected to lead to a new break, then I'll do laser.
Yeah, and so what the point I wanted to make was that when the hyaloid is attached, I actually feel to some extent it's an advantage, because when you put a buckle and the hyaloid's attached, you're rotating the break into the attached vitreous, and the vitreous itself will plug the break. When we do children with pneumatics, or we do cases that have multiple lattice with holes all over the place, sometimes just by closing one break, the entire retina reattaches because you've kind of put the odds in your favor. You've closed the main break. These young patients have very good RPE. They can absorb the liquid faster than the regulated process of fluid coming into the underneath the break. So they have a very strong pump. They have vitreous that's plugging the lattice with holes in many spots, and maybe only one of the breaks is the causative break, and you're treating that. And therefore, the vitreous in some ways is an advantage. And I think even in some cases, the bubble will compress the vitreous against the break and help it close. And why I say that is because sometimes we have very large breaks, like a retinal dialysis or something like this, where it's impossible for the bubble that I have to have tamponaded the whole break. But because the vitreous is attached, it essentially will just tip the odds in the favor of the RPE and allow the retina to reattach, even if you haven't fully supported the break. So that was my comment on patients with attached hyaloid. Don't change anything, do what you're doing, but be aware that the PVD may occur. I just wanted to check if there's any questions from the panel, or sorry, from anyone, we can address them. So here's a question: Do you laser posterior to the PVR also in this case? And maybe Jayant, if anyone posts a question, you can pose the question for us. So so do you laser posterior to the PVR? No. All you want to do is treat the retinal break and ignore the PVR that was inferior in that case because it was not contributing to the detached retina. So now let's go to this next case. So this is a patient who has a chronic.
Dr. Rajeev, there's been one more question. Like Dr. Anusha wants to know if there is any structural displacement with big bubble and how to address it.
Yeah, that's a great question. So we know that the root cause of retinal displacement in vitrectomy is a large gas bubble. When you have a large gas bubble, it applies tremendous buoyant force to the retina that displaces fluid and causes stretching. Especially when you have a 98% gas fill, all that fluid is displaced inferiorly to the periphery, and you've stretched the retina significantly, and now you are holding it in that stretched position. When you do a pneumatic, the risk of displacement is far, far less, but it's still present. And the more gas you use, the bigger the bubble you use, the greater the risk, in my view. So we have, in the past, I had an approach where I used to put as much gas as possible. So if I got a 0.5 AC tap, I add 0.3 and I inject 0.8 cc's of gas, even for a small little superior break. But now I'm more measured. So I use a large bubble when I need to, and I use a smaller bubble, minimum 0.6 though. I never go less than 0.6 because then your failure rate will increase. And I will use the 0.6 cc bubble and for a simple break, even if I could put in more gas. So that's our best approach for now. As you guys all know, we're working on viscopexy, which I think is going to change the game. And we'll be able to potentially treat some detachments without even using gas, which was the fundamental reason why I pursued an additional treatment, because I feel that avoiding gas altogether will reduce any risk of retinal displacement, will be more advantageous in terms of patient morbidity and positioning as well. So, this will come in the next year or so. But now let's talk about this case. So Francesco, what's your approach here? I have a patient with a chronic detachment. There's a subretinal band that kind of loops around in the macular region, but there's a small peripheral break at 11 o'clock with no traction on that break. The PVR doesn't extend there. So what's your just general approach here?
Well, once we are sure that there are no other inferior breaks, this can be considered also a typical case for pneumatic. I really don't matter about the subretinal bands, as I said before, because once you close the break superiorly, the retina will just settle. I think that there is almost always a good reason to do pneumatic also in these cases, because we have a single superior break. So the positioning is very easy for the patient. And even if pneumatic fails, we usually can have a good macular reattachment, a better macular reattachment than vitrectomy. So in this case, my approach will be just as a standard pneumatic retinopexy.
Great. So that's what we did. And look, the retina is attached because we closed the break. You see the PVR there. It settles nicely, and you get an excellent attachment. And in fact, look at the ELM and the EZ starting to recover already in the foveal region. So, Francesco touches on a great point that, those of us who do a lot of pneumatics will be able to see that the foveal recovery is simply outstanding, and it's very fast. So let's talk about another case. I'm going to ask Vishal to comment on this one. This is a 62-year-old male pseudophakic, very bullous inferior detachment, but all we could see was a single break at 3 o'clock. So Vishal, what's your approach here?
It's pseudophakic, and I would certainly spend some time examining the retina before I go ahead with the pneumatic. It is a case for pneumatic, considering that pneumatic was done, but I'd be very interested to see what happened after that. We would do a steamroller in a position to break with a right lateral position with zero or very minimal pillow. The only thing here is that once the laser sets in and the fluid starts to settle, you'd want to laser on either side of the break, because the way the configuration is that it's a high temporal break, because where the fluid is, and you see the fluid is going supratemporally. So I think of it as the problem I had in my case, very similar sort of position of the break. So I'd laser a few clock hours on either side, then follow up the patient a little bit. I can also see a PVD on the optos on the left. So it will evolve more after the laser and the bubble. So I keep a closer follow-up and laser a few more clock hours around the break.
Exactly. I think those are the main points. You know, pseudophakic RDs, often you can get larger bubbles if you need to as well, because often you can get a bigger AC tap. You're less worried about the lens. You know, also your AC tap, you can go in the center. Like, so usually for phakic patients, I'll go inferiorly over iris and stay parallel to the iris. In a pseudophakic patient, you can put the needle right into the center, right over the optic, and you can kind of stabilize the optic and get a very large AC tap by using the plunger that you've removed and doming up the cornea, and then causing you know, a lot of pressure to cause not just aqueous but also liquefied vitreous to come forward. But all the other things, the steamrolling, you know, expecting that there's unseen breaks, adding additional laser, you know, will help you. And here you can see in this patient, you can see just on the same day, 2 hours later, already it's starting to improve. And then here you can see, you know, on at the same day, it's almost fully attached, and the next day it's attached as well. So, you know, pseudophakic RDs are fair game. It's not a contraindication. And bullous inferior fluid, don't worry about where the fluid is. Just focus on the location of the retinal break. So maybe Kunihiko, I'll ask you to comment on your approach here. So here you have a 35-year-old female phakic who has a posterior retinal break that's somewhat it's nasal, but somewhat posterior. And you're seeing the patient in your clinic today. So what's your approach?
Mm-hmm. Because the fluid is just like the link of through. So first, I will concentrate on the single retinal break, but because it's still phakic, and in my case, I use the slit lamp laser. So in my experience, during the delivering the slit lamp laser, we cannot we can use the straight indentation. So sometimes the laser would be insufficient, and sometimes there is a risk to miss the peripheral break. So maybe I will do laser more widely than usual when we do in phakic patients. And this is because.
Yeah.
And another point of this case is the break is located posteriorly. So when we posture side posture, then sometimes there will be a risk that the bubble will not cover this break. So I will start from steam rolling, slow steam rolling, and ask the patient to never to go too much to the side position.
Yeah, I agree. And what was additionally complex here was that there was some atrophy in that nasal region.
Mm-hmm.
So when the retina attached, you know, we had to also keep that into perspective. You know, to find the break sometimes might be hard in these myopic patients where there could be some atrophy as well. But essentially, you know, this also meets pivot criteria, and I would agree, you know, this type of young myopic female. Sometimes when you have the break not too peripheral, but not too posterior, but in the middle, you can do a modified side positioning where you're half side and half face down almost at a 45-degree angle, and that can get you to fix the break. So let's switch gears now. So those were all pivot trial criteria patients. Now we're going to talk about more complex, a little bit more complex or extended criteria. So why don't we ask Francesco here? So you have a case now where it's not within 1 clock hour. So here you can see this patient has a break that might be 2 clock hours. So what do you do differently? We've already talked about pneumatics in general, but is there anything you do differently when you're dealing with a bigger break?
Well, yes. First of all, you have to be sure as much as possible to inject a single gas bubble to reduce the chances of having fish eggs under the retina. This is my first concern, because once you get fish eggs under the retina, you know, you can have success, but it is somewhat reduced success rate, first of all. The second is that in this case, we have, this is a left eye with a temporal large break. So after injecting a single gas bubble as much as possible, I usually do I never do 6 hours face down. I'm quite, that's my habit, having the patient just for a couple of hours face down. And then in this case, very slowly steamroll in a temporal position. That is, the gas bubble covers the temporal retina, and without pillows. So we are sure that the gas covers the inferior horn of the brake, and then a laser, as long as we have the gas bubble going up, you laser, after the bubble, you just follow the bubble, reabsorb, and laser the retina. Usually, in this case, I would extend my laser for at least 1 to 2 clock hours after the breaks, just to be sure to get all the retina pathology with the laser treatment. But in this case, another consideration is that when you have a large break, it is not always a bad thing, because you can express the fluid very much rapidly outside, out of the break, as compared to a couple of small holes. And after you do pneumatic for a bullous retinal detachment, but with 1 or more small breaks, the day after the procedure, you usually have a residual fluid outside the gas bubble. While when you have a large break, sometimes you do the pneumatic on the morning, and on the evening, when you see the patient, the retina is completely reattached already.
I think it's just to very quickly add that what Dr. Francesco said made a lot of sense, that you go inferior to superior as the bubble sort of zips the brake close. And also tilting the head versus using pillow. This was our discussion which I had with Dr. Rajeev, and some of the patients are given a tilt which is very uncomfortable for the patient, and for 90% of the day for 9 days is going to be near torture. So you would as well give them a flat position if you want the brake to be lower end, and then you slowly add pillows as you want the bubble to ascend along the temporal margin from temporal to superior or nasal to superior. So using thin pillows, multiple of them, can really help move your bubble according to which clockover you want it to work. And then a no pillow will make it, more horizontal, along the more horizontal meridian. So that is more comfortable for the patient and increases the compliance of positioning.
Yes, and another thing we do here when we have, somewhat inferior breaks, for example, this is not the case because it's a superior break, but when we have inferior break, and I have a case, if you want, we can show later, we have a tilting bed, so we can put pillows under the head of the patient to get him or her comfortable, but just to tilt in the television position to get the bubble going in the inferior retina. So the patient is comfortable with the neck, but we can tilt the patient's body just to have the bubble in our preferred position.
Yeah, no, I think these are all excellent points. And, sometimes with large breaks, you'll also see here that the posterior edge of the break is a little folded. And sometimes that happens, and sometimes it doesn't fully unfold, and we'll just laser around that little fold. And usually that doesn't cause an issue. But I liked all of the comments specifically about avoiding fish eggs, slow steamroll. And we published a paper recently on something called the mini steamroll, where when you have a large gaping break, even 10 minutes of face down will express most of the fluid through the break, and the retina will miraculously be almost fully attached in 10 minutes in your office. And then you don't need to do the full steamroll. You can just go straight to the break in that situation. So these are all excellent points that were raised. So let's switch gears to another case. And Francesco, we'll try to get your case in soon. So if you can,
we have two questions pending. So maybe
ready.
before proceeding,
let's do the question.
One question is by Dr. Anusha. She wants to know that how often do you encounter lens feathering after pneumatic retinopexy, and how do you reassure the patients?
So I'll take that question. Lens feathering is very interesting You don't get it with pneumatics. The only time I've seen it happen in a pneumatic was when I was very aggressive and I put a very, very large gas bubble because I was trying to do a case with inferior brakes. And I ended up putting a double gas bubble in a patient with an attached hyaloid, and I used C3F8, and I think I almost had like a 90% fill. I think what happens is when that expands to the point where you're almost filling the entire eye, and there's no movement of the bubble against the back of the lens, like the bubble's always in contact and pushed against the lens, I think you can get feathering. I think it can go away many times, but I had one case where it caused a posterior subcapsular cataract for an inferior dialysis. And so it didn't cause a real issue. We didn't have to remove it actually because it wasn't affecting the patient too much. But so in the range of gas bubbles that we use, you're almost never going to get feathering. That said, if the patient lies on their back, you can get feathering. And we just did a case now, which was a failed pneumatic. And we were just talking about that, how when a pneumatic fails and you're booking them for surgery, it's critical that you tell the patient to be strict face down until they see you in the operating room. Because even if they're face down for a day, but then they come to the OR and the nurse tells them to lie on their back, so they put the IV in and all of this, in that 1 hour, and when you start your vitrectomy, you'll get feathering very quickly with the infusion and everything. So the key is to remain strict face down until you get them to the OR when a pneumatic fails. Otherwise, there's very low risk. What was the second question?
The second question is about overfilling. So there's one of our audience is little concerned if we are unable to get adequate tap and say we get only 0.1 cc of the tap, how
Yes.
do we prevent the risk of overfilling? And like the person is scared about the risk of vascular occlusion.
Yes,
So you can
understood.
tell your formula.
Yeah. Yeah, so basically we inject 0.3 more than what we take out. That is the standard, but we never put less than 0.6. Even if, let's say I take out 0.2, I would not hesitate at all to do 0.6, and I know I would probably do a retap after. If I took out 0.15, I would also probably go to 0.6. Now, if I got 0.1 and it flattened very, very quickly, okay, in that case, maybe I would go to 0.5, okay, but never less than that. But essentially, that is extremely rare. I would say 1 out of several hundred cases where that happens. I can assure you, and we have data now on over close to 2,000 patients that we're going to publish on the IOP changes. IOP is a non-issue in pneumatic retinopexy. What happens is that the pressure will very quickly rise. You don't need to panic. Even if the patient is NLP, you do not have to panic. You keep them face down for 3 to 4 minutes. You put in the speculum, put in the betadine and the anesthetic, and you do a retap. Now, when you do the retap, you go inferiorly over iris for phakic, and you can go more in the middle for pseudophakic. For pseudophakics, this is almost a non-issue because you can get large taps. But in phakic patients, you go inferiorly, and maybe you'll get one little drop out, and the iris will start, billowing towards the needle, and the chamber will flatten, and you come out. Whenever you do the retap, go in slowly and come out slowly because you're going into a hard eye. You don't want to jut in too quickly and damage tissues. And when you pull out, you don't want to come out so quickly because the high pressure could drive the iris towards the needle track. So you go in and come out very slowly, but you do not need to worry because what's going to happen is the eye equilibrates very quickly and the chamber reforms and you can repeat your tap. Even sometimes in 1 or 2, once in a while, I'm going to have to do 2 taps or maybe even 3 taps. How many times, we have some of our fellow here. So Isabella, how many times in the last 2 years have you had to remove gas when we do this? Never. So all you need to do is not worry, not panic, be patient, face down, and repeat the tap until they're pulsatile. When they're pulsatile, then you have a lot of time to wait, and you can just retap as necessary. So here's a case where this is also an extended case where you have many breaks, lots of lattice, maybe even lattice 360. I think we're on Kunihiko. So Kunihiko, extensive 360 lattice, atrophic holes all over the place. what are you thinking for this, something like this?
Even if there is a lattice surrounded by lattice, it's not a contraindication for pneumatic. If there is no detachment in the on the other side. So first, we must laser completely around the lattice junction, lattice in the attached retina, and then we can inject gas. And in this case, there is many holes in the detached retina. So probably only one injection would be insufficient. But first, I will inject 0.6 or 0.7, and as the patient keep side steamroller and side positioning, and wait for one or 2 days until expansion of the gas, and complete laser. And if I can't complete laser, it's particularly when this is a chronic detachment and it takes some time for the reabsorption, absorption of the fluid, then I may consider another gas bubble. But I guess in most cases, one single bubble would be work in this case.
Yeah, and again, because the hyaloid's attached, you've covered the main breaks superiorly. Things have a tendency to settle very quickly. And remember, just because there's a break in detached retina even, it doesn't mean that that break is recruiting fluid, right? So let's say you have multiple atrophic holes in a 6 clock hour temporal detachment. Based on Linkoff's rules, probably the superior breaks were the ones that caused the detachment. So even though you have a break at 5:30 in fluid, it doesn't mean that that hole is allowing fluid to recruit or recruiting fast enough that it's going to compromise your pneumatic success. So you can do the pneumatic even though you actually can't tamponade all of the breaks in a case like this. And I agree with you that using second bubbles is very helpful. We find that when let's say you have a case of pneumatic that's starting to fail, that half of those cases can be salvaged by putting in a second gas bubble. So before I go to the extreme pneumatics, Francesco, do you want to share the screen and show your case?
Yes.
Meanwhile, we can take a question. Dr. Wahidullah wants to know if we can also do a vitreous tap in cases where we feel that there is a need.
Well, so I feel that I think they're referring to the vitreous tap for the gas, or you're just in general from the beginning for the pneumatic.
I guess it's when we realize that the pressure is high and we just need to do more tap.
That's the worst case scenario. So if my fellow is in there and they're in their first month and they're panicking and they put in too much gas and they can't get a good AC tap, the patient's still in LP, this once in a while, because I'm not there, I'll just say, fine, take a little bit of gas out. But I would say this is extremely unlikely that you would need to do this. And of course, for a pneumatic in a vitrectomized eye, maybe some have argued you can do a vit tap and then inject the gas. But don't forget the retina is detached. So when you aspirate from in the vitreous, you could pull the retina towards the needle, which is not good. So what I find in vitrectomized eyes is that a lot of fluid will come through the AC. So I don't need to do a vit tap. So I essentially never do a vit tap for the purposes of a pneumatic, and very, very, very rarely, especially early in your experience, I've seen that done a couple times for when they put in too much gas, but that's essentially a non-issue. So sorry, Francesco, why don't you go ahead then?
No problem. Just a quick case, maybe a simple case for Professor Muni, but here it's not this way because we are doing less pneumatic than you. But anyway, we know that what are the indications, contraindication on pneumatic. Here it is not mentioned a retinal detachment with inferior break, but as Professor Muni teaches, we can reattach almost any kind of retinal detachment with the pneumatic, or just to try it and also have a success. And this is a typical case for a pneumatic. Here we can have a 100%, almost 100% success rate. This is a picture taken from the internet. And this is the case of a total retinal detachment, bullous, of a lady, middle-aged lady. She's Italian, but she lives in Switzerland, and she came back for the mourning of the mother. And she began noticing flashes 3 weeks before. She is myopic in both eyes. Vision in the right eye is hand movement. She has a somewhat mild cataract, nuclear cataract in both eyes, and she has a total retinal detachment with an inferior break, inferior nasal break, a single break, no other pathology in the remaining retina. This is the OCT. I'm sorry we don't have optos images. Anyway, this is the situation. We have a total retinal detachment with a just inferior break between 4 and 5. So why to choose pneumatic retinopexy here? This can be a point of discussion. Our plan was to put gas bubble a couple of hours face down, then steam rod to the right with no pillows in a Trendelenburg position as much as possible. We do pneumatic differently from other people. I know that this is just a matter of habit, and a lot of people, they can, you know, don't like this way. This is a colleague of mine doing retinopexy. We do an AC tap as large as possible until we have some reflux of blood from the angle, single good bubble in. Then we give a look at the posterior pole. Maybe necessary a second, paracentesis. So in order to have the bubble to cover the inferior break, if you put the patient in this position, you can have the inferior horn of the retina free of tamponade. So we have to put the patient in this position and or have a larger gas bubble, and we can achieve this with a longer expanding gas such as C2F6 or C3F8. But as Rajeev mentioned before, we like doing a second injection rather than to have a longer acting gas such as C3F8, because when we have retina reattached, we don't really need the gas anymore. So I agree totally with him that instead of having a longer acting gas, it can be somewhat preferable to give a second gas injection. This is just a couple of hours after injection. As Muni mentioned before, we can have a better appearance of the retina just a few hours after injection. And this is the postoperative day 1. We have done the most of the laser, but we have some residual inferior fluids in the anterior inferior horn of the break. So we decided, so this is the situation of first postoperative day. We did a laser and we have a displaced fluid inferiorly, temporally, and here nasally. So we decided to inject the second gas bubble. When we inject the second gas bubble, we just do the same procedure as the first one, and we have the patient head just in somewhat upright position, just to be sure to inject the gas bubble into the first one. This probably may cause also less turbulence of the vitreous cavity. And you can see here up how big is the gas bubble. I'm sorry, I don't have optos images, but this is the first postoperative day, the gas bubble with a 55 angle lens. You just see a little bit, but here you see a longer, a larger, very large gas bubble. After a few days, we added most of the laser, and this is the last follow-up. Then the patient went back to Switzerland. We have a retina completely attached and a complete laser scan. This is the OCT. The patient at the last visit, just 1 month ago, or a couple of months ago, sorry, she already had 0.7 visual acuity. I'm sure this patient will recover 20/20 with time, and she complained of no anisoconia and no metamorphosis. She was really very, very happy. So we can do a lot of comments here, but I approach inferior tears with the pneumatic retinopexy only in highly motivated patients. For example, patients who have no problems with posture. In these cases, when I have an inferior break, I just anticipate the patient that we can have the necessity to inject a double bubble on postoperative day 3, usually. When I began doing pneumatic 10 years ago or more than 10 years ago, I did a lot of cryo, but nowadays I really prefer doing laser because it is less inflammatory, less PVR, less discomfort for the patient. We do cryotherapy just in a few cases, you know, when you are sure that the patient is not able to cooperate with laser or for some other cases. Thank you very much.
So Dr. Francisco, we have two questions maybe which you can answer. They are very close to your case. The first one is by Dr. Rohini. She wants to know how to decide about how much gas to inject while re-injecting.
Yes, this is a good question. I almost never do calculating the AC tap. I never inject less than 0.6, and in myopic eyes, I usually inject 0.7. And in pseudophakic myopic patient, I usually inject 0.8. The maximum amount of gas I injected so far of SF6 is 0.9 in very highly myopic pseudophakic patient. I know that this is not you know, a precise calculation, but it's just my habit. Probably with more experience, I can move toward a better calculation of the gas with the AC tap.
Okay, and Dr. Rajeev always prefers laser over cryo. Dr. Anirudh Soni wants to know, like, how is cryo in comparison to laser in pneumatic, and can cryo be done prior to injecting gas? So
sorry,
yeah.
sorry, please.
Yeah,
Go
Dr.
ahead.
Rajeev, please go ahead.
Yeah, sure. So basically the cryo, you know, I do like both, but I feel that laser is better. And the reason is because you get some immediate adhesion from the laser, whereas with cryo, you get no adhesion for 5 days. So if you have a patient who stops positioning at day 2 or 3, and you cryo to superior horseshoe tear, and they stop positioning, it's going to redetach from that same break. Whereas if you saw them on day 1 or 2 and lasered that break and they stopped positioning, it's like any horseshoe tear, and it's unlikely to redetach. Also, we talked about the cases like the pseudophakic RDs where you want to laser more than just the break. You want to laser a couple clock hours in every direction. I think if you're doing lots of cryo, that's a disadvantage. However, there are some cases where I prefer laser. Patients who are difficult, patients with very small pupil, capsular phimosis, patients maybe where there's some VH. You know, again, VH and cryo are not always a good mix, but very judicious use of cryo in the setting of a poor view. Children are good with cryo because you know it's all done and you don't have to rely on them to comply for the subsequent laser. You know, these are the types of cases. Patients who are aphakic because the gas will come in the AC, and then when you're trying to laser, it's almost impossible to see. So these are some examples. Pseudophakic cases, very tiny breaks where you really want to be sure you've treated the break. But in those cases, some of the cases where, for example, a pseudophakic RD, I'll add laser after the cryo, after the retina is attached, I'll go around the cryo area and further supplement my barricade. You don't want to laser over the necrotic cryoretina, but you'll go around it. So many times if we did cryo, I will supplement with laser, but the reality is the majority of the time we do laser retinopexy. And as Kunihiko was mentioning, he also likes doing slit lamp laser, which I don't do. I do almost exclusively indirect laser. Even my PRPs I do with indirect, so I'm just used to that. But you can adequately treat cases with slit lamp as well. Kunihiko, do you have any tips on slit lamp laser? Like what can really make a difference in terms of getting peripheral and getting a view?
Yeah, and the most important tip for the slit lamp laser is to use the adequate lens. So if you use a good lens, which you're familiar with, then you can do laser to the very periphery, to aura. If the but in pseudophakic eyes or if the dilation is not good, then it's very difficult. So in such cases, I prefer to add cryo in the most periphery, or if the patient is not very good for for doing laser. So and another disadvantage of slit lamp laser is inferior break, particularly inferior horseshoe tear, which has some traction. Then in such cases, during the slit lamp laser, the gas bubble cannot cover the inferior break. So sometimes during laser, the peripheral retina at the horseshoe tear will detach soon. So sometimes it's very difficult to do slit lamp laser inferior break. So in such cases, I add cryo.
Yeah, so ultimately both are very useful. You know, also some of our colleagues in the US or other places, they move around and they're not always in the same place. And one key of pneumatic retinopexy is the person who puts the gas in and examines the retina at baseline has to be the one following. But sometimes that's not possible because doctors move to different offices and someone else is following the patient. I like doing cryo in those cases because then you know the treating surgeon saw and treated the break, and you're not leaving someone else with a poor view trying to find the break, you know. So I'm going to move into a few more challenging cases. We don't have too much time, maybe 10 minutes left. If there's any questions, please let us know. This is a patient with a superior break, chronic total RD, and a choroidal. And, you know, choroidal detachments are perfect for pneumatic retinopexy because you're addressing two things. You can close the break and you can address the raised, the hypotony. And so here you can see we were able to attach the retina fully and the choroidal nicely resolved. The key is don't do your gas injection where the choroidal is, obviously. So because otherwise when you pull back that needle, or you won't be in the correct space and you'll inject the gas suprachoroidal, which is not the end of the world. You get a suprachoroidal buckle, but it's not what we're trying to do. So be aware of that. Go in a different quadrant. Probably insert your needle a little more deeply so you really feel that you've gone through the wall of the eye, and then inject your gas when you pull back. So this is another case. When you have a very posterior radial break, you often will need two bubbles in a case like this. And so after one bubble, oh my God, it's much worse. The whole retina is detaching, it's bullous, but we don't have to panic. We know that we just need more gas. We put a second gas bubble in, and here you can see excellent recovery of the case. And here it freezes again every time. So just any comments from the panel on those two cases, choroidal detachments or very large posterior breaks?
Just a question, the face down when you have a posterior large break as the second case is always the same for you, or you just, you know, change something in your management of the patient in the first postoperative hours?
Yeah, so what I do in these posterior breaks, often they look more posterior than they are, first of all, when it's bullously detached. So it'll often get better when you attach the retina. So I just do my usual steamroll, face down 6 hours and gradually raise the head. Now, on day 1 or 2, if I see that the inferior aspect of the break is likely not covered, and that's why the retinal detachment is not settling, then I will add more gas and re-steamroll and try again. But sometimes you have to do this awkward 45-degree face down where they're not face down, they're not sitting up, but they're in the middle, where you're placing the bubble at the, you know, in the posterior to the equator region where you can get that posterior aspect of the break. So once in a while, we'll do that. Like that other myopic patient we showed that had a more posterior break, same thing. So this is another case. Here you can see the patient has multiple horseshoe tears all over the place and even had breaks in attached retina inferiorly. We lasered all of those. You see, we put lots of rows around these breaks. And here we did a marching laser with a single gas bubble. We gradually positioned the patient and lasered all of the retinal breaks. I'm going to skip this one. This is a patient with an inferior dialysis. Remember, I was telling you, like, even when the hyaloid's attached, you can have breaks that are very big and inferior, and they work amazingly well. Sometimes when you're not even tamponading the break fully, and it allows you to attach the retina in a case like that. So maybe I'll ask Vishal, how about, have you had any experience with dialysis types of cases? I don't know if Vishal's still there. Maybe Kunihiko, any comment on dialyses?
I think once dialysis happens, the remaining traction is very small. So in my experience and in my knowledge, sometimes my friends say large dialysis is a contraindication for pneumatic pexy, but I don't think so. In these large dialysis cases, the traction is not much traction is remaining. So the gas bubble will work well, and pneumatic pexy is very good for such cases.
Yeah, so I agree completely, and the hyaloid's attached, which helps us as well. So this is a 33-year-old female, asymptomatic. You know, we see these now and then, right? But it's too posterior to barricade. So the question is, what are we going to do to this case? You know, I can't barricade, so I got to do a buckle. So I wanted to try a pneumatic in a case like this, and this is an example where I put in 2 C3F8 gas bubbles, 0.6 cc's each. And here you can see this very inferior and posterior lattice with holes. And you could see here that this is day 1 with 0.6 C3F8. And this was on day 2. It was starting to attach. And on day 5, we put another 0.6 cc's because we couldn't get the full inferior aspect of the break attached. And then you could see here that we were starting to win. Now you're noticing a little bit of lens feathering here. You can see the view's a little bit hazy, but you can see that this patient did very well. And this was an asymptomatic RD that we did not have to make them symptomatic by doing a buckle where they're going to have other issues. And we were able to attach the retina and laser around the break. And I think I just want to add with this GRT case, I will end with this and maybe have a few comments at the end. This is a patient, huge break. And what's very unique about pneumatic retinopexy that we don't often understand is that it's not just about tamponading the break, but it's also about the buoyant force of the bubble and using that to your advantage. So when you have a GRT that's folded over like this one, all you do is put a gas bubble and put them face down. As long as you can get the retina underneath the flap, the posterior flap that's folded over, and put them face down, that bubble applies so much buoyant force that it prevents fluid from coming in anywhere in the break, and it pushes all the fluid out. And with the face down positioning, the GRT unfolds. So look, at 60 minutes, you've already attached the retina. You know, issues with slippage, less risk of displacement. You've turned you don't need to use PFCL. You've turned a very complex situation into something that's very easy. And then we were able to laser the retina 360 degrees. And just to give you another, I'll show you one last GRT case. Here, this is another case where you would say, well, how in the world are you going to do a pneumatic here? And all I'm thinking when I'm doing a pneumatic in a case like this, can I put the bubble on the non-detached, non-folded over retina? If I can get the bubble anywhere on the retina where the GRT is not folded over, the buoyant force of the bubble will do the rest. And look at this. At one day, you've attached the full retina, and then we started doing laser all around, and there was some fluid creeping in from the nasal side of this almost 6-7 clock hour GRT. And here you have it. Fully attached with not an inch of displacement, and that's my talk on pneumatic retinopexy for you guys today. So if there's any questions, please let us know. Otherwise, I would just say if there's any final comments from our panel.
Well, my comment is in a general retinal tear or in a very bullous retinal detachment. I mean, I have no so much experience with general retinal tears treated by a pneumatic retinopexy. Anyway, in cases like these or a very bullous retinal detachment, I think it's just important to give a chance to pneumatic retinopexy, because when you have a bullous retinal detachment with the macula involvement, and you try pneumatic and it fails, it is not such a tragedy, because you usually do for a vitrectomy in a less detached retina, less fluid, and a macula reattached. So the visual acuity, final visual acuity, can even be better than a primary vitrectomy. This is just my comment. I mean, when you have a failed pneumatic, it's not a big failure, you know. It's always a chance to give a try, you know, to pneumatic. In the worst case scenario, you have a less detached retina treated by means of pneumatic with no harm for the eye.
And I'd go back to what Kunihiko said at the beginning. When you're starting and you're just new, just start with very simple cases. We showed you a very broad array of cases, but you don't need to go to those from the beginning. Go to a single horseshoe tear. Those will, superior horseshoe tear will almost have a 90% success rate, and you'll feel very confident. You'll gain experience with the laser. And we posted the link for our chat group. Whoever's not a member, you're welcome to join. And all of us, you know, Kunihiko, Francesco, Vishal, we're all on there, and others, many others are on there to give feedback almost in real time. Like today, there was a guy who did a pneumatic and had a gas bubble in the anterior hyaloid trapped. And, you know, you had 3 or 4 of us helping the guy through this case. So don't be, you know, pneumatic is something that you can amazingly learn in a virtual environment. And we're all there to support you guys. So do your cases, post your pictures. If there's a problem, you know, just post it and we'll tell you what to do and what our experience is. So I'd like to thank, I think I'll hand it over to Jayant, who's moderating. Yeah, thank you all for coming.
And Dr. Rajeev, we have a question like, how commonly do you see epiretinal membranes after pneumatic?
Yeah, great question. You know, we've compared the risk of ERM in pneumatic versus vitrectomy. Even from randomized controlled trial data, there's no substantial difference. You know, the ERM formation can occur after vitrectomy and after pneumatic, and it's essentially the same. I would say it's extremely rare that you would have a, you know, very aggressive ERM forming, but after vitrectomy, we see it, and after pneumatic, some cases you'll get this lot of pigment present in the vitreous and this rapid ERM forming. And over time, I've learned to treat those sooner rather than later when you get that rapid aggressive ERM. But many patients with RD will have a stage 1 ERM that essentially doesn't need to be treated. But we haven't seen a big difference between pneumatic and vit. And one other question that was here, I just saw it, was how difficult is it to laser through the bubble or move the bubble away from the laser? So, you know, does the panel have any comments for that question? Like, do you prefer to laser through the bubble or do you prefer to move the bubble away? I like to laser through the bubble because it minifies the view. I get a wider field. Somehow the view is a little more clear. I like to use a 28 diopter lens. I think there's a steep learning curve. It takes like a few 40 cases to get really good, but that's what I like. How about you guys?
Well, I don't have a slit lamp laser, so I do like Kunihiko throw a slit lamp. Sorry, I don't have you know, a Goldman indirect laser. I just have a slit lamp as maybe Kunihiko or other people. So when we have a superior break, you have to laser through the gas bubble, unless you have a really extreme tilt of the head of the patient. But in those cases with the slit lamp, when you do laser through gas bubble, it's very important not to over-treat with the laser. You just have to be sure not to cause overheating of the retina of the break. Sometimes you don't see whitening of the retina and you still have some adhesion. That's my comment with the slit lamp laser.
Yeah, Dr. Rajeev, one question, like, how did you manage to inject gas over the attached retina in that superior GRT case? The last one which you showed.
That's a great question. So what I would do in a case like that with that superior folded over GRT, I'm usually injecting temporal or nasal. So what I would do is have the patient lying on their flat and then maybe I'd have them like kind of looking to the right temporally, and I'll inject nasal. And then as I'm sitting them up, I'll sit them up in a way that they're face down essentially right away. And then I'll, kind of very timidly kind of peek and make sure I have a single bubble, because if I don't have the single bubble, I'll keep them face down longer. And then I'll just say, okay, now the bubble's in, it's a single bubble, you're face down, and just stay like that for 10, 20, 30 minutes. And you'll see the GRT will unfold, and that the retina will largely attach very quickly. So inject away from the GRT, make that the highest point, and then get them face down somehow with the bubble under the posterior flap. And then once you start to get the bubble under that flap, everything's going to recover beautifully because of the dynamics from the bubble, as I was discussing.
They leave your OR in face down position?
We don't do these in the OR. We do them in our office. Yeah,
Okay.
We have them just sitting there in the chair, or they go to the waiting room, they stay face down, and we'll check them again in a few hours. Yeah. So.
And any experience in using PNR in failed scleral buckling cases for advanced PVR changes?
Yeah, I mean, for failed scleral buckles all the time, you can use it. It's actually I think the original description of pneumatic by Ed Boldry was in the 70s for failed buckles, and that's how the whole procedure started even, I think. So, it can definitely be done. In PVR situation, it's slightly different. You have to think about why the detachment is failing, and if it's an open break that you've missed, or the break's fish mouthing, you can definitely use a pneumatic. But if there's a traction issue, then that's different. If there's a traction issue on the break.
And have you realized that there are any stages in acceptance of pneumatic retinopexy amongst the vitreoretinal surgeons? The first stage will be denial, I'm sure. But then
yeah. So, I've been fighting this battle, we published the pivot trial in 2019, and essentially that showed everyone what we all who do a lot of pneumatics knew, is that the outcomes are better. And initially there was denial, a lot of denial, but people adapted and started using it in simple cases. And I purposely, even though at that time I was already doing GRTs, I was doing inferior breaks, I never talked about it for 3 or 4 years. Only in the last 12 months, 18 months have I started talking about the complex cases, because I've noticed that the uptake for routine cases is a no-brainer. In some ways, if you had a superior retinal break, anyone here raise their hand, put up your hand if you had a superior retinal break, 12 o'clock or 11 o'clock, that you would want a vitrectomy. Let's say, assume you're 50. If anyone wants a vitrectomy for, and I think when you ask a room full of retinal surgeons, they're all going to say, no, I don't want a vitrectomy. They say either a buckle or a pneumatic. And so if it was my eye, I had an inferior break, I'd want a buckle. If I have a superior break, I'd want a pneumatic. And vitrectomy would be the last thing I would allow a surgeon to do on me. So why should I do anything different for a patient? And I think that now you're seeing, in our different chat groups, and in the Americans who are under 50 retinal surgeons, probably half of them are doing pneumatics on simple cases. And in India, I think it's taken off like I've never imagined. I don't know why. Maybe it's related to the healthcare. Maybe some of our colleagues from India can comment on this. But I find that in places like India, South America, where there's already a huge burden of population and access to the operating room, it just makes no sense to make a patient, pay for a vitrectomy, get to the OR for an inferior outcome. So yeah, to me, it not only is it cheaper, it's better for the patient. So I feel that whether you're in the US or in some rural village somewhere, this is the best initial approach. But when it fails, that's the art. You need to learn when it's failing, when it's not working. Don't be in denial and move on to the next surgery. Then you won't cause any harm, and that's our main thing. We don't want to cause harm.
Can you give us an idea of how many cases are you virtually guiding daily, on a daily basis, on WhatsApp and various groups?
Every day when I wake up, I have 2 or 3 WhatsApp messages from people all over the world, particularly in Asia, that are doing a pneumatic and they want to know their basic feedback, like how do I do this? It's their first case or second case. So essentially every day I have a few messages. Either it's a follow-up on a case or it's a new case. And then many times they're posted on the chat group, and many of us will respond. So you've seen our chat group has grown from maybe 100 people not so long ago, like in COVID, and now almost 1,000 people. And what we're also noticing is that the community is demanding more knowledge about this procedure. So, for example, at this year's American Society of Retina Specialists, a huge focus is on pneumatic retinopexy. There's going to be a lot of talk about it. At EU Retina, at all of these meetings, they've asked us to, present repeatedly. And, as my friends here know, like we've been traveling a lot in the last year or two, like almost to every continent. Last year I traveled around the world 3 times to every single continent, and as in many countries. I'm taking a break this year. I'm doing less travel, and I'm trying to get these guys to give the talks eventually. So, there's a huge interest in this procedure at the moment. And I feel that it's the real hesitation is when you have our older colleagues who have never trained to do it, and they're not comfortable, and then it trickles down to the juniors. But I think most of the juniors, those under 50, 55, that are still able to learn new techniques, they're all learning it, and especially the young surgeons, so, for our young colleagues, I would say that when you become trained as a retinal surgeon, you never want to not know how to do a procedure. You want to be able to do a pneumatic, a vit, and a scleral buckle, all with expert treatments. And so you want to be able to do anything so that when the patient comes, you have an engineer or a physician who has a 11 o'clock single break. Don't do a vitrectomy, do the pneumatic because you're confident doing them. So you have to do all of these procedures, and you have to do them with enough numbers that you're confident. And then you'll pick the right case, the right procedure for the right case. The worst thing is to do a fellowship where you've only learned vitrectomy for regulated cases, dysregulated, for inferior breaks, superior breaks, and all you have is a vitrectomy, then that's all you're going to be comfortable doing. So now's the time, learn it. If you need social media, we're all here. Learn how to do the procedure. Force yourself to do on the simple cases and get really good at it, and you'll overcome this learning curve, and then you'll be able to use it on the patients that you want to use it on.
Thank you, Dr. Rajeev. That was a real nice class and session for all of us. We had simple to all complex cases, crazy cases, I would say. And any closing comments from Dr. Kunihiko or Dr. Francesco? You all have been really helpful in today's session and in answering all the questions.
Vishal,
Also, Dr. Vishal.
Yes.
Dr. Vishal, I think he has left, but he was really good in guiding us initially. Yeah. Thank you, Dr. Francesco, and thank you, Dr. Kunihiko, for taking out your time.
Thank you, everyone.
Thank you. It's my pleasure.
It was a pleasure having you all.
Yeah, and anyone who has more questions, we'll keep the chat running, and we'll continue to answer your questions. So thank you all. Have a good evening in India and Japan and Italy. And I'm going back to the operating room now. So take care.
Thank you. Thank you.
Thank you so much, everyone.
Thank you.
Bye-bye.